Good morning, everyone. Welcome to the web show, It's All in Your Head. My name is Angie, and I am here with Dr. Paul Swingle today to talk about autistic spectrum disorders. Before we begin, I would like to tell you a little bit more about Dr. Swingle. Prior to moving to Vancouver, Dr. Paul Swingle was Professor of Psychology at the University of Ottawa. A Fellow of the Canadian Psychological Association, Dr. Swingle was a lecturer in psychiatry at Harvard Medical School, an attending psychologist at McLean's Hospital in Boston, where he was also coordinator of the Clinical Psychophysiology Service. Dr. Swingle is a registered psychologist in British Columbia, certified in biofeedback and neurotherapy. His newest book, Biofeedback for the Brain, was published by Rutgers University Press, and it is available on our website at soundhealthproducts.com. During this webcast, you are welcome to send us questions. We will have 2 Q&A breaks to go over these questions. So please do not hesitate to send them to me. You can also do so by using the chat box that is located in the control panel. Okay, so let's get started. Let me welcome Dr. Paul Swingle. Good morning.
Okay, as I started to say, we're going to be talking about autism, and autism is a very complex set of conditions, and it ranges from very seriously delayed individuals to individuals that are very high functioning and sometimes with exceptional skills and capabilities. There are various dimensions that run through this concept of autism. The one dimension is Asperger's versus autism, and we'll be talking about a lot of those different issues as we proceed. It also looks as though we're reaching epidemic kinds of proportions associated with some of the conditions affecting our young children, autism being one of them. I mean, the estimates now are running as high as 1 in 78 children, more prominently with males relative to females, but nonetheless we're seeing a lot of females as well with certain kinds of these restrictions and challenges which we tend to understand as autistic in nature. Now, I'm going to be talking about how we assess what's going on in the situation, how we treat it presently, and some of the very exciting breakthroughs we're having in terms of being able to become much more precise in terms of addressing the putative mechanism associated with some of these challenges. We're going to be working, of course, with the electroencephalogram, and that's the EEG, in which we're measuring brain activity at these 19 sites shown on your screen now. We're measuring the electrical activity coming from the brain, and then it's broken down into the various waveforms. And the brainwave activity, a particular area of the brain, gives us an idea of function, level of activity, interconnectivity, and so forth. So let's get started. This is a male child, 3 years, 3 months or so of age, and typically what we do is we gain measurements, take measurements from 5 positions on the brain for openers. Now, it's important to remember that early on there were some clinics that were treating autism, but they would only treat autistic children at a later age, and they would only treat them if they could get a full electroencephalogram. That is all 19 sites. Now, for anybody who has experience with autism knows that that cuts out about half of the population, because half of these children simply can't have a full EEG done unless it's done under sedation conditions, and that's not a true EEG. So what we do is we bring the child in and get as many locations as possible on the brain, but we start with those that are extremely important. In this case, we were able to obtain 4 measurements on this child, and you can see, according to the mother's report, severely hyperactive, speech delayed, sleep disturbance, attention problems, unresponsive to feelings of others. Now, I'm going to show you what these numbers mean in terms of how we assess what the situation is, but much more importantly, it gives us a guide to where we're going to start treatment. Typically, when we're dealing with severe hyperactivity, we're looking at two areas of the brain. The back of the brain tends to be deficient in slow frequency amplitude, so there's a problem with quieting. But if there's too much very slow activity up over the motor area in the brain, that area of the brain is hypoactive, underactive, and the child is bouncing around to self-medicate. It's hard for us to realize sometimes and appreciate that it's painful for the child to sit still. And what they're trying to do is activate that level, that area up over the motor strip by bouncing around. Now, autism is often a little different. Here I've highlighted the areas on that schematic that we had earlier. This child has a lot of slow activity up over the sensory motor strip, which is what I was just showing you before. So there's the area associated with the hyperactivity. It also interferes with the child's ability to focus, by the way. We also have another measurement, again in this area, in which there's a brain wave that's associated with involuntary movement that is very low in this child's case. This is what's called the sensory motor rhythm, and it is the brain rhythm that we use when we're treating epilepsy, for example, and other seizure disorders. So we know immediately that there's a problem in the up over the sensory motor cortex in the brain. So we know one place we can start treatment. We can light up, so to speak, that is, activate this area. The second area is sitting right here over FZ. Now, what I have here, the number associated with that is indicative of how active a subcortical region in the brain, referred to as the anterior cingulate gyrus, how hot that is. This is the most important area to measure on an autistic child when they walk in the door. If I get nothing else, I want to know about that site. That's the area associated with perseverative activity. And a lot of autistic children, for example, will get captivated by a pattern in the floor or by an object like a microwave oven, for example, and that's all they think about, talk about, and want to look at. What that is hyperactivity of that region, the anterior cingulate gyrus, and it's the same region associated with obsessive compulsive disorder. Now, it is important, if we find out that's hyperactive, that if we're trying to arouse this area of the brain, we don't make the situation worse by arousing this other area of the brain, which is only millimeters away. That's why we want to measure it first. Second, the frontal cortex, F4 is the right frontal cortex, F3 is the left, and this child has imbalances that are associated with poor interpersonal interaction, for lack of a better way of describing it, in which there's marked elevation of slow frequency sitting up over this region in the brain. Okay, so we didn't take a full cap. Child is hyperactive, screaming, but we know what to do to start. We know the areas that we can get a handle on this and start treatment with this very, very hyperactive, challenged child. Okay, female, 52 months old, and here are the numbers associated with this condition. And according to the parent report, delayed speech and social skills, poor comprehension, perseverative behavior. Now remember, when I hear that, I want to look at FZ. I want to look at the anterior cingulate gyrus, because what she's talking about is obsessive or compulsive behavior and sleep problems. Okay. So what do we know? Let's go to my fancy drawing. Well, the first thing we know is our little friend here, the anterior cingulate gyrus, is hot. In her case, it's sitting at 0.7, and something around 0.5 would be better. Okay. We also know that we've got elevated alpha activity right across the front part of the brain, and that's a dysregulation factor. And we also know that there's elevated alpha in the right side of the brain relative to the left, and that's the poor social interaction and so forth. Exactly what we saw in the other child. Now, the two similarities we have between these two cases is elevated alpha in F4 and hyperactivity in the anterior cingulate. Okay, but we don't have that big problem over the sensory motor strip. Okay, so this area of the brain, the right side of the brain, is very important to have a look at in autistic kids. That's where theory of the self resides. That's where interpersonal interaction resides, areas associated with emotional volatility and so forth. And the motor strip sitting up over the top here, there we were concerned about areas associated with hyperactivity, among other things. The back of the brain, which we haven't seen yet, often we have some problems back here, either too much slow activity and the child is out in la-la land, or severe deficiencies in which the child can't quiet. Left side of the brain, we have to watch for anxiety markers in this case. And our buddy, the anterior cingulate gyrus, sits right in here, right between those hemispheres. Okay, now some children walk in with diagnosis of ADHD, bipolar, all kinds of things, and this is another diagnosis we get with children that show the same kind of profile. And this is pervasive developmental disorder, not otherwise specified. This is an 8-year-old child, and according to parental report, unhappy, obsessive. As soon as I hear obsessive, I want to know about my buddy, the anterior cingulate gyrus. Anxious, mood swings, impulsive, talks loudly, sleep disturbances, fear of family members dying. There again, I want to see the anterior cingulate gyrus. Remember, there's a fixation factor here. Well, I know it's hot, sitting at 0.97, and again, we want it down around 0.5, 0.6, something like that. So let's see what we've got here. And you can see we've got a montage of things going on here. Again, we have our buddy, the anterior cingulate gyrus, is hot. We have elevated alpha over here, which is the social interaction problems. We've got elevated slow frequency right across the frontal part of the brain, which gives rise to cognitive sluggishness and among other things. And it also can implicate issues like hyperactivity or mood swings, that talking loudly kind of thing, so the inhibitors are not in place and so forth. Excuse me. There's an area also associated with elevated activity over on the right side of the brain in terms of beta, which is a depression marker. And if you recall, the parent described this child as unhappy. And in the back of the brain, what we have is marked elevation of slow frequency, so a real problem staying in the present. Do we have some similarities? You bet. We've seen this before. We've seen this in every case we've had, and we've seen this in every case we've had. That is complications of the right side of the brain. Now, our buddy, the anterior cingulate gyrus, is sitting right here. The cingulate gyrus runs the entire distance subcortically, But we're interested in the anterior or front part of that. That's the culprit in terms of perseverative thought and behavior. Okay, 8-year-old, child with autism, at least described that way. Compulsive, I want to know about the anterior cingulate. Unable to sit still, I want to know about the activity, slow activity over the sensory motor strip. Self-stim and humming, I want to know about the anterior cingulate. Unable to follow through on tasks, and that can be related to all kinds of things, but primarily slowing in the front part of the brain, often associated with elevated what's called alpha activity. We'll say more about that later. Aggressive, I want to know about imbalances in the front part of the brain, unresponsive to others' feelings. I'll bet you a quarter we're going to find that the right side of the frontal cortex is hypoactive relative to the left. Okay, and that's one of the markers for this problems with interpersonal skill. Okay, so here we go. First of all, our buddy, the anterior cingulate, is hot again. By the way, we find circumstances in which it isn't. Here's our other buddy, that is elevated activity of the sensory motor cortex, causing us all kinds of grief. Elevated slow frequency in the back of the brain, so he's just not able to stay focused and on target. And we've got a problem associated with elevation of slow frequency right across the front part of the brain. We have the right side having elevated alpha activity, which is that unresponsive to others' feelings. That is where theory of the self resides. And we've got a situation in which the theta-beta ratio is higher on the left relative to the right, and that can be associated with mood state. Also, we have some elevation over an area that's associated with the aggressiveness and impulsivity that the mother was talking about. Now, what this tells us is what to do. And it's identifying the fact that we want to balance the front part of the brain. We want to decrease the elevated slow frequency amplitude sitting over the sensory motor cortex, that is the motor strip. And we want to decrease that elevated slow frequency in the back. We want to cool down our buddy, the anterior cingulate. Okay? So we know where to go, what to do. In other words, treat the condition, not the label. And that's the most important message we learn when we're doing neurotherapeutic treatment of anything. The label is meaningless. It doesn't tell us anything about what to do or where to go in the brain to be helpful. So generally what we're looking for is we're looking for elevated slow frequency amplitude, and it can be anywhere. If it's over the sensory motor strip, we're concerned about motor activity, front part of the brain, cognitive slowing. Elevated activity in the anterior cingulate gyrus. Frontal alpha imbalance, where we have a lot of slow frequency over on the right prefrontal orbital cortex. That's one of the hallmark features associated with the social problems that all of these children tend to have. The mirror neuron system, which we'll talk about a little later, but basically that's the mechanism associated with the ability of the child to learn by watching you. So it's the imitative neuron system that the child learns by observation, and that system is typically deficient in children that are suffering from this kind of activity. Autism is highly related to seizures. About 25% of autistic kids have a seizure problem. This is a woman, Arlene Martel, mother of Adam. We saw Adam when he was, I don't know, 5, 6, 7 years of age. I can't remember actually. And Arlene was an extremely courageous mother. They told her to institutionalize Adam, put a crash helmet on him so he wouldn't hurt himself with the thrashing and so forth. And she would have none of that. This is Adam in a tuxedo, graduating from high school. So we did a lot of neurotherapy on Adam, and primarily the first order of business is get that seizure under control. Adam has been written up in all kinds of places, but here she's talking about in that article that he only received a few sessions, and the teachers were remarking on how drastically changed Adam was. And the seizure issue is a very, very major problem. This is a drawing, not of Adam, not by Adam, but another autistic child, and I always like to have this to remind myself. This is a child whose interpersonal capabilities are severely, severely delayed. Very poor ability to interact with other individuals. But look the way she's drawn this. This is not a tracing, by the way. She's drawn hundreds of these. Look at the social interaction going on here. And I use this to remind myself that one of the ways of looking at this is that all of this is locked up, and what we're looking for is the neurology to release it. Now, how do we treat this stuff? The first method of treatment is one that most people are familiar with, and it's brainwave biofeedback. There we set it up so that when the brain is doing what we want it to do, icons move on a computer screen for a child. So basically they're playing a video game with their brain. When the brain's doing what we want it to do, you know, cartoon characters move around the screen. When it stops doing what we want it to do, they stop. Slightly more advanced, it's a game structure in which when the brain's doing what we want it to do, Pac-Man moves across the screen and gobbles up dots, and there's a score. Okay, brain driving is not using instrumental conditioning, which is what brainwave biofeedback is. Something positive happens, you reward it with something, in this case a cartoon moving. Brain driving is classical conditioning, just like Pavlov and his dogs. We measure brain activity, and when we're trying to increase or decrease it, we apply a stimulus that has the effect of either increasing or decreasing that particular activity. So we're conditioning the brain to behave in a more functional manner. Now, brainwave activity looks like this when we're measuring at any particular area, and this is the spectrum at one site going from very slow frequency, 0.5 cycles a second, up to very fast, 40 cycles a second. And one of the things you should see is that there should be an algorithm that is amplitude strength of a waveform should be inversely related to frequency. So the slower frequencies have the stronger strength, and that's exactly what you see. There's a nice healthy brain. The brainwave activity is broken down into waveforms. So here's the raw signal coming out, and we break it down. So we take out of this signal what is theta activity, 3 to 7 cycles a second. We take out of this what is alpha, 8 to 12 cycles a second, and we extract from this what is beta, 16 to 25 cycles a second. Okay, and those are the waveforms that we can work with. And this is the spectrum analysis, so we can see what's happening live when we're treating a child. This is just a sample of classical conditioning. Sound does not have a suppressive effect on alpha activity. So when you present sound, nothing much happens. When you present light, you get a suppression of alpha activity. Now, just like Pavlov and his dogs, if you pair the sound, which doesn't usually suppress alpha activity, with light, which always suppresses activity, you can arrive after a few training sessions to where you turn the sound on only, and you get a nice suppression of alpha. So there's brain driving. There are other mechanisms. You can do it with time as opposed to any other stimulus. But the point is, the brain learns, and it learns either with instrumental conditioning or with classical conditioning. Omni is a sound that suppresses slow frequency amplitude, so it is, as we say, an unconditioned stimulus for suppressing slow frequency. Now remember, one of the big problems with these kids is elevated slow frequency over the sensory motor strip, CZ, right on top of the head. And just a simple exposure to this sound reduces the amplitude of that slow frequency by 22%. So we've got an unconditioned stimulus that if we pair it in a proper fashion, we can teach the brain, condition the brain to respond with less slow frequency amplitude. And just as an example of this is a hyperactive child, an ADD child, not an autistic child. But here's that elevated slow frequency that we see in these children relative to children without that condition. And what Omni does is it suppresses the amplitude of that. And if we pair it in a conditioning manner, we can give some stability to that suppression.
Thank you, Dr. Swingle. This is the first Q&A break, and I have a couple of questions. The first one is, what is the difference between autism and Asperger's?
Oh, yeah, I mentioned that earlier. The general distinction that people apply here is that an Asperger's child wants to interact with you. They recognize you as a social being. The problem is they don't have any social skills. They don't know how to read your emotional state. They don't know how to read your face gestures, your body gestures. And these are the children that will come up, stand on your feet, and look at you in the face. Their face is 2 inches away from you, and yell at you. Hello, Dr. Swingle. How are you? My name is Johnny. Okay. Now, Adam, by the way, one of the jokes we have is Adam used to do exactly that. He would come in and stand on my toes and yell at me. And he was going to go out on a date when he was, I don't know, 19 or so. And I was joking with him. I said, remember, young ladies don't like their toes stepped on. Okay, now the difference with an autistic child is there's a serious problem in the right prefrontal orbital cortex, and in some areas, which we'll talk about a little later, they don't recognize you as an emotional being. You don't exist in an emotional sense. So it's not that they are trying to interact with you and don't know how. You're not there, so there's no reason to interact, so to speak. So that's the essential difference that we're dealing with.
Okay, the second question is, I heard that the rate of autism has grown markedly over the past decade. What is the reason for this? Are we just calling more problems with children autism?
And, I think there's an element of that. We have autism funds, so it's financially beneficial to use that, slap that label on almost anything if you can do it. But taking that into account, there is a marked elevation in the frequency of these kinds of conditions. And my personal feeling is we have absolutely destroyed the environment for children. And what we're doing with all of the pollution and all kinds of other things is we have set up a condition in which the very vulnerable brain is being adversely affected. How much evidence do I have for that? Not a lot. There are a lot of studies that look at the frequency of autism, for example, with pregnant mothers who live very close to roadways, big interstates and so forth, where there's a lot of, presumably a lot of carbon pollution and so forth. And the frequency of autism is higher in those areas.
Okay, thank you so much. I just want to remind everyone, if we don't have time to answer all your questions, you can also send them to me via email at angie@swingleclinic.com, and we will continue with the webcast.
Okay, so continuing with the brain driving, one of the things that we do is we present lights. Now remember, we can suppress certain waveforms by turning lights on. Okay, and here's a situation in which the person can look right through those lenses, and the lights are located in the periphery, so we can turn lights on to stimulate through the eyes, and the child can be watching a TV screen, they can be reading, they can be playing puzzles, they can be interacting with me, having a conversation, and so forth. So we can present the stimuli even though the child is engaged in other activities, and that is a huge advantage. So a lot of the work we do with children who have problems with reading and written output and ADD and all the rest of it, we have some remarkably fast changes because the child can be performing a task while the relevant area of the brain is under treatment. There are the glasses, and you know, it's set up so that we're monitoring all of the brain activity. In this case, the child can be playing Pac-Man while we're helping him with brain stimulation at certain times. When theta, for example, gets to be too high, we turn the lights on, suppress it, so that we're classically conditioning while the child is involved in brainwave biofeedback. So it's a very, very efficient system. This is an adult, obviously, and we can hook it up so that we are presenting sound. We're doing electrical stimulation of acupuncture points, lights, and so forth. So it can be a very, very efficient and aggressive treatment for conditions like severe depression and so forth. This is tasking, as we were describing, you know, doing brain driving while the child is engaged in some activity, in this case writing. And this is the first session. The only thing the child was able to do was to print his name. Second session, third session. And this is, I'm sorry, this is over 5 sessions. Okay. So you can see we have a marked improvement in this child's ability to express what he could probably do under the right circumstances in a variety of different conditions. Remember that early cartoon that I showed you? We may not be teaching, we may be releasing. Okay. This is some early work I did when I was chairman at Ottawa University. I was head of the faculty of child psychology, and this was an effort to try to teach autistic kids how to cooperate. One child could hop on this, and the other child would come over here and push this lever, and if he pushed the lever like once every 3 seconds, it would provide power so this other child could ride. And we were trying to get them so that they would understand the concept of you ride, I work, I ride, you work kind of thing. And we had some very, very interesting results from that, combined with brainwave, with neurotherapy. These kinds of activities, these kinds of training situations can be enormously effective. We've already talked about the seizure disorders with Adam. This is a child with a seizure disorder. And the big issue here is up over the sensory motor cortex. There are other areas implied in this, but that's one area that we're always looking at, and that's highlighted in red here. And the effect of anti-seizure medication is it increases slow frequency in the front part of the brain, among other areas. And so you get increased slow frequency in the front. You get a slowing of alpha, which is a measure which is related to IQ. You get slowing in the front part of the brain. You get slowing over the motor strip. And all of these are the side effects of the anti-seizure medication. So the pediatric neurologist is caught between a rock and a hard place. If the child has uncontrolled seizures, then you have a high probability of death. If you medicate, and in the severe cases heavily medicate, then the child is developmentally delayed. So what we're interested in here is what's going on right over that sensory motor strip, and here is where the sensory motor rhythm is very important. That child had a ratio of 6 point something or other, well, why don't I go back and actually find out what it was, 613. And we want it down below 3. So I know immediately that I've got some leeway here to try to get some improvement in the seizure activity. Now here comes a balancing act in terms of it looks like this is improving, and how do we start with the titration off the anti-seizure medications? It's not an easy thing to do, and we need very close cooperation of everybody working with this child. And again, the culprit here, in terms of the seizures, are sitting right in this region. Again, there are a lot of other areas associated with seizure. I'm not trying to oversimplify here. But remember, we brought the child in and we're able to get a few measurements so we have an idea of where to start. I want to point out that it's very important that the person working on your brain, and particularly on your child's brain, be licensed and certified. We have a lot of franchises popping up, one size fits all, and any bored perfume salesman who has warm blood and a checkbook can go out and get himself a system and claim to do neurotherapy. You want to be very, very, very cautious. It's advertised that it's benign, there are no side effects. Well, if it has powerful beneficial effects, by definition, it has to have the potential for severe negative side effects if the person working on your child's brain is not a licensed healthcare professional. They should bring other things to the table besides neurotherapy. Now, two examples here. One is, you remember we were talking about our buddy, the anterior cingulate gyrus, and we were just looking at a situation in which what we want to do is we want to decrease the amount of slow frequency over the sensory motor strip to help this child with epilepsy. If I do that without watching what's going on the anterior cingulate, I will make that child's condition considerably worse. Okay? So it's important that the person messing with your brain, or your child's brain, can read and write, as we say. Now, this is a harmonic, and the effect of the harmonic is that it increases the sensory motor rhythm. Now that sounds exactly what we want to do for the treatment of an epileptic, right? We want to increase the strength of sensory motor rhythm. Now, the problem is that very often what you get is you get an exacerbation of the theta activity. Now, in this case, it looks like it's working pretty well. So we get a nice reduction in the theta SMR ratio when we're working with what we call Mozart. You can get exactly the reverse. So it's very important when you're using these products that people are talking about that you're monitoring what effect it's actually having on the brain. Here is a situation in which although it's increasing the sensory motor rhythm, which is what we want, it's markedly increasing the theta amplitude, so we're getting a 50% increase in the theta SMR ratio. In other words, although it is affecting one of the waveforms that we want to benefit for the epilepsy, it's markedly exacerbating another waveform that will make the seizure threshold drop. In other words, we're working against ourselves. So we have to know what the product is doing at all areas of concern.
Okay, this is our second and final Q&A break. One of the questions we received is, would it be beneficial to diagnose someone at 18 years of age, or does the diagnosis have to be at an earlier age for the treatment to be effective?
Neurotherapy is effective at any age. We have individuals with traumatic brain injury come in 30 years post-accident, and they get benefits from the neurotherapy. The closer to the accident, the more efficacious. The younger the brain, the more plastic, etc. However, there are no circumstances in which you should not consider neurotherapy. That is in terms of age and time since trauma.
Great. And the second question relates, how far can you go with treatment? Can the child or person ever be normal?
Normal is a drier setting. The issue associated with this is how serious is the problem, how rapidly did you figure it out, and how close to the developmental stage are you? So, for example, if a child is going through the developmental stage associated with attachment, social interaction, so forth and so on, and we're able to get that system online, so to speak, then that child may respond with minimal indicators of any awkwardness. If the child has long passed that developmental stage, then he's going to maintain some awkwardness because you've missed the putative stage associated with that development. Just think of learning a second language. If you learn a second language when you're 3 years of age, you'll speak it like a native. If you learn it when you're 40 years of age, you are going to have an accent, period. And the reason is in the second stage, you're learning it in an area of the brain that's not associated with the same learning if you took place when you're in the developmental stage associated with language acquisition. So, at any age, how far can you get? As I say to the parent, we may hit a brick wall in terms of how far we can go. But now here the issue of optimal performance becomes important. When we're working with athletes, once we get them to their superb base state, then you want to optimize. And if you think of a bodybuilder, once a bodybuilder gets body into great shape, the person doesn't sit down on the sofa, watch TV, and eat pretzels. It maintains it. And the same is true when we're dealing with a challenged brain. In order to get and maintain optimal level of performance, you're very likely to be looking at a continuous treatment. Now, I don't mean necessarily coming into the office for neurotherapy, but some well-prescribed, well-thought-out, and well-monitored procedure for maintaining the optimal level. We have autistic kids who were thought to have the potential for being permanently disabled who are actually working now. Starbucks, for example, will often hire challenged kids. Now, in that context, the individual often is coming in to see us on a once-a-month basis. They're working, so they're maintaining their interpersonal skills. Okay? So we've taken it a little above the brick wall that we've hit.
Thank you, Dr. Swingle. We will continue with the webcast, and again, if we weren't able to answer all of your questions, you can feel free to email them at angie@swingleclinic.com.
Here's something that we use as a home treatment, just to give you an example. It's referred to as emotional freedom technique. I was introduced to this about 25 years ago, and I thought it gave nonsense new meaning. I was sitting in a seminar, and they were telling me to tap various areas on the body. You know, you tap this area on the hand, then you tap on the edge of the eyebrow, the edge of the eye, under the nose, under the lip, on each side of the, below the collarbone, under the arms. And what it's supposed to do, it was called the instant phobia cure, I think, at the time. And they said that it would help with addiction. And I have to admit, I am severely addicted to coffee. So I'm sitting there with a cup of coffee, and I'm tapping, and all I could think about at the end of it was having another sip of my coffee. So in any event, after fiddling around with this, I actually do what I always do with these things and brain map it. What's going on with the brain? What I found was very interesting, and that is this tapping procedure increases the sensory motor rhythm. And here we have it here, tapping, and you can see the sensory motor rhythm increases. Now, that's body quieting, which explains why it helps with phobia, but it may be very, very beneficial for seizure problems. So what we do is we teach individuals, parents teach the children, and what the best of all things is the child and the parent do it together so the child learns how to do it. Tapping these acupuncture points. Now the other thing is we find that often it will increase theta as well as increase the sensory motor rhythm. And if that's the case, what we want to do is we want to add Omni. Now remember, Omni suppresses slow frequency, so they listen to Omni while they're doing the tapping, and this is the kind of benefits that you get in terms of the use of this acupuncture tapping procedure. And here we have an increase in the sensory motor rhythm by almost 50%. And here we have an autistic child, 27%, an ADD child, 14%, epilepsy, 28%, and so forth. So this is what I mean by a well-regulated, monitored home treatment procedure for maintaining optimal functioning in a child who has a seizure issue in addition to autism. Okay. Now, let me go back. What we've been doing thus far is I've been talking about if we see an elevated waveform here, elevated alpha, for example, that often is associated with the interpersonal problems that an autistic child has. So what we want to do is we want to suppress that elevated slow frequency alpha. In other words, get it balanced between the right and the left. We also talked about the fact that in some forms of our hyperactivity, for example, we get elevated slow frequency up in this region. So what we do is we put electrodes on that area, and either with neurotherapy or brain driving, we suppress the amplitude of that particular waveform, similar to the back of the brain. But we're treating surface. Okay? What's going on underneath? Where are the generators of that slow frequency alpha, for example, slow frequency theta? If you show this pattern to an autistic child, very frequently what they will see is A, and they will be highly repetitive associated with that. They will not see the big picture, and the big picture here is W. Now, we know that the hippocampus is implicated in the ability to organize big picture, and it's associated with a huge number of issues here in terms of the ability to filter out stimulation and only attend to important stimulation. It's important for the organization and integration of memory, emotional content, memories, and so forth and so on. There's a lot of information about this. and we know it's implicated in autism. In other words, it's an issue associated with the big picture. Now, oxytocin is a neurotransmitter that affects the reduces the effect of stimuli coming into this region. In other words, it makes it so that you need stronger stimulation to engage these systems. And the problem that the autistic child has often is they can't sift out the importance of various stimuli. Okay? Autistic children apparently, in some cases, respond well to this treatment. That is, you give them oxytocin. Now, we are addressing the hippocampus directly, and I'll show you how we're doing this. This is the exciting development that's taking place in neurotherapy. The other area that's associated, and I'll show you the brain neurological architecture of this in just a minute, is the amygdala. The amygdala is critical in emotional processing. It's a small structure about the size of an almond. And here it is in terms of the structure. Now you'll see that here's the hippocampus, and the amygdala sits right at the base of that. And it's in the temporal lobe, and it's bilateral. Okay, why am I having grief? Okay. Okay. Now, up to now, all we've been able to do is look at the architecture. And we can do this with surface electrodes. And what we do is we put the EEG cap on, and using those surface electrodes, measuring the activity, the brain activity, in this case beta, at various points, we can figure out where it's coming from. And that's kind of like oceanographic software, you know, in which they send sonar down and they look at the rebounds and they can get some idea of the architecture at the bottom of the ocean. So using a similar kind of concept, if the generator, in terms of when does it arrive at various places, then you can figure out where it's coming from. And this looks like it's sitting on top of our old buddy, you know, the cingulate gyrus. Okay, but that's post-treatment. Okay, we can take a picture and see where it came from. But now, this is just another version of it in which we're slicing through the brain and having a look at where these areas are coming from, where those brain waves are coming from. We can do direct subcortical treatment. Now this is live, so we can see what areas are lighting up while the brain is under treatment. So here's our buddy, the hippocampus, and the amygdala is sitting right on the edge of that. And the question is, if we're able to determine that slow frequency, for example, is coming from this region right here, then we can treat this with surface electrodes. And that's exactly what we've been doing for conditions such as severe eating disorders, severe personality, core emotional belief problems, self-loathing, and all that sort of business. But it looks like we may be able to get direct access to this via surface electrodes. And there's a treatment that's used for very extreme, serious treatment refractory depression, in which it looks like from the front part of the head we are able to get direct access to the amygdala area. And this is just another shot live. This is being lit up. This area is lighting up, and these are the electrode points on the head. So we may have an electrode here, and we may be presenting light or sound or microamperage stimulation, all kinds of things to try to either light up or inhibit a particular area. And we've been using things like very, very weak magnetic stimulation. So for example, if we can increase slow frequency over our buddy, the anterior cingulate gyrus, so that we're increasing slow frequency, meaning we are reducing the activity of that region, then we may be able to cool that off in a much more efficient manner than what we're doing now. And I think what we're doing now is very efficient, but a lot of these are very, very exciting developments that we're doing here at the Swingle Clinic in terms of treating some of these extremely severe conditions. Remember, normal is a drier setting. What you're doing is you're optimizing brain functioning. And it doesn't matter if you're dealing with a severely challenged, developmentally delayed child. You bring them up to optimal functioning of what it is, what their capabilities are, and then you optimize a bit. And one final thing I'd like to comment on. We've been focusing on the child and the autistic child, the challenged child. The problem that we run into is the parent, the caregiver, is not paying attention to their own condition. And you can make a huge difference in your child's well-being by taking care of yourself. And we often forget that. And if we look at the vulnerability statistics here, they're compelling. Now, all this is looking at somebody who is in a stressful circumstance. And the stressful circumstance is doing math and being interviewed by aggressive interviewers, okay? This isn't even in the same ballpark of what a lot of you folks are dealing with. And look at the effect on cortisol. Cortisol, of course, increases in response to stress, okay? Looking at strangers, looking at a partner, even looking through a one-way mirror, even looking at a video of it. Men and women are equal, and as we all know, women admit it. Okay? Thank you.
Thank you, Dr. Swingle. That was extremely informative. I will now conclude the show with a few announcements. First of all, for all of those of you who are interested in learning about neurotherapy, this book is a great resource. It is called Biofeedback for the Brain. Dr. Swingle is the author and would like to think is the most important book you'll ever read for yourself, your children, and grandchildren. It is available at soundhealthproducts.com. This is the Clinician's Guide, and it is literature for professional therapists. The book leads therapists through the procedures for evaluating and treating patients with a wide range of disorders, and it's also available online at Sound Health Products. Our next advanced workshop is scheduled for October 24th to 26th. It is a 3-day workshop where participants will be instructed on every aspect of the setup, recording, and treatment phases so they can apply the assessment and treatment procedures in their practices. We have more information on our workshops on our website at swingleclinic.com under events, and you can also email me at angie@swingleclinic.com. Due to popular demand, we will have another free public lecture at the Vancouver Central Library. It will be in October as well, October 30th at 7 p.m. You can find more information under events at swingleclinic.com. And if you enjoyed this webcast, you will be happy to know that they occur every month. These are some of the future topics for the year. We will be discussing addictions, learning and attention disorders, anxiety, depression, emotional trauma, and more. All of these have been scheduled on our events page at swingleclinic.com. If you are a professional, Dr. Swingle also offers online training through the Biofeedback Foundation of Europe. You can visit the VFE's website at www.bfe.org to see all of the offerings of Dr. Swingle's webinars and online courses. The professionals who complete the courses can get up to 24 hours of continued education. And And as you know, we have a variety of products through Sound Health Products. If you would like to get more information about these, we encourage you to visit our website at soundhealthproducts.com and also our Facebook page. And this is the end of today's episode. It was great having you all, and we certainly hope you enjoyed the show. We will be back live on August 9th to discuss the neurotherapeutic treatment of fibromyalgia, chronic fatigue, and pain. Have a great weekend, everyone.